Like you said, Minnesota has is one of the healthiest states in the nation, and as you've heard from everyone, I'm sure continue, is that we do have one of the highest health disparities. The good news is that Minnesota as a state has been taking on this issue, and it's been one of the leaders around the nation. And in fact, we're one of the few states who have been making headway on health disparities. Since 2001, we've been providing over $5 million a year to community-based organizations that reflect the populations that are being served, which I think personally is one of the most important parts of our initiative. And in 2009, the legislative session passed for us to continue that funding, and we will continue to provide those services. There has been a priority place that we do move more to the system level, so that we're addressing the health disparities before they're started, so more upstream, as our commissioner likes to say. And also to integrate the priority of eliminating health disparities throughout Minnesota's Department of Health, so that all of the divisions have that as a priority and that they're addressing that with all of the work that they're doing. For health reform, it definitely is one of the systems that can affect eliminating health disparities by providing access to populations of color around HIV/AIDS, diabetes, cancer, all which have morbidity rates that are high among our populations because of lack of care, because we have late diagnosis. So by providing that access, it's a great step in the right direction. But if we don't have people in the systems who look and talk and who are able to understand the culture and just linguistically be able to talk to people where they're at, that access is not going to be used. We have to have people who there can participate. So I was really happy when you talked about the workforce to serve in underserved communities. And then I got a little deflated when it didn't talk about emphasizing the fact that these populations need to have people who look like them, in them, whether they're speaking a language or not, that has to be a priority. So I would ask that when you go to Washington, you look back at your own state and really take the lessons that we have learned through this initiative and bring them forth so that we can continue to succeed.
I think that is very important, and I met at the University of Minnesota Duluth with, they're trying to get American Indians and become medical professionals. Only 4 Native people last year took the MCATs in the entire state. You know, culturally appropriate care is so important. I just read the book, The Spirit Catches You When You Fall Down, and that is sort of a landmark book on that. And it is, there's just, at least people are talking about that now, and I actually hear that discussion. And that's heartening, and I'm glad you brought it up. Patricia.
Thank you. I just want to tell you a little bit that I'm 55% clinical, so I'm still seeing patients, and I direct the HealthPartners Center for International Health, so I'm seeing refugees and immigrants, and that'll be just the focus of my comments is around health disparities with refugees and immigrants. But I also teach at the university. We've got a great global health program at the university, one of only 13 in the world. And then I co-chair HealthPartners Health Disparities efforts, so working at the system level on improving care, and actually co-chair all of our data collection efforts. So we actually implemented in 2004 what we call granular ethnicity, which is collecting race, ethnicity, language, and country of origin. And I really liked what you said about your neighborhood determining your health. And I think I have 2 key points to make. One is that sort of like what Thomas Friedman said, that the earth is flat for business. It's absolutely the way it is for medicine too. That we're really in Minnesota and all over the country practicing medicine in the global village. And in some places we're doing it really well, and in some places we aren't doing it very well. In fact, if you look at, it's kind of 2 key things. One is globally mobile populations. We're creating a center for migration medicine at the U. 185 million people move around the world every year. And that reality is only going to increase over time. So how do we deal with that in the context of providing care that really is culturally competent? how do we train the next generation of providers, and how do we set up our health system so that if you don't speak or read and write in English, that you can actually call your doctor. And so I think one message is around that the global is local in healthcare. So in Minnesota, 85% of our TB is in the foreign-born. There's much more HIV in foreign-born African patients compared to their percent in the population. Most of the malaria we see. So that's the reality. And how do we change our health system to account for that and do a good job for everyone? What I resonated with what Representative Ellison said about we have to make sure this isn't extraneous, and we have to raise the bar enough so that we say for every single person who walks through the door of my clinic, whether it's in Minneapolis or Worthington or anywhere else, I'll know their neighborhood. And their neighborhood might have been Laos or Somalia, so we need to know those diseases, and we need to do a better job caring for this globally mobile population. And then the second point is that there are lots of experts in Minnesota on refugee and immigrant healthcare. So a lot of them are around the room here, but we're really seen as the national experts in this field, publishing books on it. And the Center for Global Health and Social Responsibility at the U, the Center for International Health and HealthPartners, La Clinica, other neighborhood clinics that are really focusing on immigrant communities. So we want to be a resource to you in that arena. We've got lots of specific detailed statistics, and lots of the Center for International Health that I direct has been doing this work for 27 years now. So we're really happy to help in any way we can. Maybe I'll just end with a story, which is a little bit of levity, but an example of how serious the issue is. We had a Somali patient come in and say that he'd been bitten by the hyena, and he saw a physician who was working with an interpreter who it was a different dialect between northern and southern Somali. So the interpreter thought the doctor might not know what a hyena was, so said, "I've been bitten by a dog." So that patient started the rabies post-exposure series, and actually the colloquialism for "I've been bitten by the hyena" is "I have syphilis." And so that patient got the wrong medical care for many reasons, but is a good example of the kind of thing we hear about a lot and experience a lot, that we have to understand that your neighborhood, and the world is our neighborhood in Minnesota, is how we're experiencing healthcare, and what can we do to provide good care, educate the next generation. Lots of great things going on in Minnesota. I chaired the Immigrant Health Task Force, which took 70 stakeholders around the state and came up with 8 key recommendations about refugee and immigrant health, and I've given those to Amy. So, but thank you very much.
Well, you gotta know these culturally correct euphemisms, like I've been walking the Appalachian Trail.
Oh yes, I've heard of it.
Thank you. That was really Dr. Sarah had him over. He and his wife over.
He understands that the global's local.
Yeah, he's very good.